Welcome out there to another wonderful episode of Nurse to Health, brought to you by and in collaboration with the Hofstra Northwell School of Nursing and Physician Assistant Studies, with the wonderful support, as always, of our station manager and best in the business engineer, John Mullen. This is going to be a interesting episode. My co-host, Dr. Nagdala, welcome.
Hey guys.
Kareem, how are you? And I'm Dr. Robert Gluck, both of us with the School of Nursing and PA Studies, and we're joined by Lara West, who is the head of the PA program for the entire Northwell system, which is huge already and constantly expanding. So I'm sure there's a more official title, and we'll let you get into that. Again, I'll be very simple in describing Scott Gould, who is the head, and again, I'm sure there's a more official title to that, of the Physician Assistant Training program here, which is one of the outstanding programs in the country. So welcome, both of you. And
Thank you.
Yeah, you're welcome. Thanks for being here. And before we get started, we were talking outside. This happens to be, just coincidentally, happens to be National PA Week,
That's right.
which I just found out. I mean, I researched this a little bit. Happens to coincide with the birthday of one of the founders of
Correct.
PA, which is Eugene Stead, who is a doctor at Duke, and maybe we can get, in fact, not maybe, we'll get a little bit into
100%.
that. That was back in the 60s.
Absolutely.
And I'm going to use that to frame this discussion. I'm going to go back to my days as I guess it was a first-year medical student, which was in the late 70s, believe it or not. And I was at Einstein Medical College. I was up at Montefiore. So we were doing a surgical rotation. I was in the OR. They were doing a kidney transplant. At the time, I was just a medical student. Didn't know all that much, but notwithstanding that, I was incredibly impressed by the technical skills of what I thought was the primary surgeon. And I remember coming out and said, wow, who's that surgeon? He's incredible. It happened to be the surgical first assistant, who was a PA. And I was blown away. And again, this is going back 40, 50 years. I use that to frame the discussion because PAs can do incredible stuff. Personal experience, most of my career was spent as a surgeon in orthopedics and, had the constant assistance. I mean, occasionally it was residents, but more often than not, it was PAs. So, I have incredible respect for PAs. Having said all that, right, there's a lot of discussion, which is going to frame this episode in terms of, and this goes back to the 60s. What's the scope of practice? How autonomous can they be? And it's state by state and all this.
Right.
And we've had the same discussion about nurse practitioners, would fall into the category of, advanced clinical providers or advanced practice providers. So again, I just use that to frame this discussion. But I'm going to start with a real low-hanging fruit kind of question. Which is it? Is it physician assistant or physician associate or both?
Great
or
question.
Something else. So
No, great question. I think we can start with the history and peel the onion on that. So first of all, thank you for the invite.
You're welcome.
Appreciate being here. This is my first experience on a podcast. Lara West, Assistant Vice President of Advanced Clinical Providers. ACP is a term at Northwell Health that encompasses PAs and Ps and midwives. So I help support both PA and NP profession as well as the midwife profession. We are 4,300 strong across all of our hospitals and ambulatory practices. So it's a job that is sometimes difficult, but a job that I love doing because I know that I'm helping support those that are helping support the patients. But if we can peel the onion on, is it physician assistant or a physician associate? It really goes back to the history. And you kind of framed it a little bit in the beginning. So in 1960s, with the concept of Medicaid and Medicare, and also with the concept of these physician shortage, I don't think either one of those concepts are new to us today or stuff that we're not thinking about today,
maybe
right?
it's getting worse, right?
Correct.
Arguably, yeah.
Correct. So it's about health insurance, and it was about shortage of primary care providers and access, correct.
And by the way, just to frame this for our non-professional health professionals out there, that shortage translates into lousy care. I mean, let's just be blunt. I mean, people are rushed, right? They're not focused, et cetera. So anyhow, I'm sorry.
Correct.
Go ahead, yeah.
So you mentioned Dr. Eugene Stead, the founder of the PA profession. I love telling the story because we forget this part. He actually started with nurses, and he was looking to create providers that can fill that gap in between the patient and the physician. So he started this program with nurses. It didn't really flourish. And then he saw these Navy medics that were coming back home from war, who had all of this experience, hands-on experience. You mentioned, the orthopedic PA in the OR, but they didn't have the didactic portion. So he created this program in 1965, which was the first PA program in the country through Duke University. And out of the four, three of them graduated. And it has become really the fulcrum of what the PA profession is all about, is taking folks who have healthcare medical experience and then pouring in that medicine gap that is missing, and then kind of bringing them in to close the gap in healthcare.
Yeah, so these guys hit the ground running in terms of their experience. Like you said, they were Navy medics, so they were primed, they had background. So it seems it's a concept that makes a lot of sense, right? There's a need and they're filling it. How much pushback did he get at the time, if you know?
Initially, there wasn't a lot of pushback. It was only a few years later, in the early 70s, 73, when the AMA recognized the physician assistant. So
Right.
it
Is that-
wasn't. Yeah.
Right. Yeah.
There was, like you said, the recognition of the need in the care model. So I don't think there was a lot of pushback because it was recognized relatively quickly. The national board certification for PAs came a few years later than that. When Duke started the program in 65 and 67, it was only a couple of years later that Emory built a program. So it started to grow quite rapidly. And I think that's probably where the recognition from the AMA and other bodies said, this is a real thing. There's a real need for
Right,
this.
and that's ongoing. So I'm going to sort of build off of that because, look, the AMA pushed back. There's turf issues, and follow the money. This involves egos. It involves money. It involves all sorts of things. And just as a matter of full disclosure, we're kind of. I just want to tell our listening audience, we're kind of ganging up on you, right? 'Cause you're surrounded by an MD and a nurse practitioner. So, we've had this discussion before, and we'll continue to have it because obviously there's tensions. That's real, and we say on this program we try to bring you behind the curtain and to the front lines, and we want to keep it real. So I'm going to turn it over to my nurse practitioner colleague. What's your thoughts, Kareem?
It's interesting that you guys spoke about the history. I think the listeners have had a good amount of time hearing about physicians and nurse practitioners, but they really weren't introduced to physician assistants. So a physician assistant today, like if they were part of a healthcare team, what does that look like in terms of providing patient care? What is the scope of practice, and how does that integrate in with a nurse practitioner and a physician?
And if I could just refine that, just so Lara, specifically for you, I guess as for Scott as well in terms of training, Northwell is a leader in a lot of ways. So just how does Northwell deal with that, and are we distinct from the rest of the world?
Mm-hmm.
Yeah, I think, Kareem, we have over 200,000 PAs now across the country. And PAs are recognized also internationally in Africa, in Canada, in other places. PAs are seeing close to 590 million patients a year. We have 315 programs across the country, all of which are a minimal of 2 years to 3 years of experience. So I think the patient population is very well aware of the PA profession, and many will choose to see a PA because there is that interaction and that time that the PA will take. So the PAs are trained in a medical model because of Dr. Stead, right? They took that physician way of teaching and training and encapsulated into the PA program. The difference here is that the PAs are spending that extra time with that patient that the physician, when we were speaking about being rushed because of the shortage, right, the physicians may not necessarily be. And listen, I was trained by a physician, love my physician counterparts, have a tremendous amount of respect for them. I think what the reality of the country here is now is that we have way too many more patients and too many sick patients than we can take care of. And so it's about a collaborative approach, whether you're a physician, a PA, or an NP.
What's the gap, that physician gap that the PAs and NPs are filling? Do you guys have like a ballpark range of that?
I don't know. I've read numbers that, they're expecting tens of thousands of shortages in physicians, right? And they're talking about the aging out of the baby boomers, right?
Yeah.
For the first time in our history as a country, there are more people over the age of 55 than under the age of 55. So you get to 55 and older and you start to need medical needs. Not only that, but in that 55-year-old group and older are physicians and nurses and NPs who are retiring.
Yeah.
So you have
Right.
the people who would normally give care to that population are part of that population now. And so that's what's creating these gaps.
Bureau of Labor Statistic data is very clear, I think, for a while now. So the projection for MDs, physicians, is there's going to be an increasing shortage.
Yeah.
It's not getting better. the projections going 5, maybe 10 years out is for PA population, NP population to increase by 20
30%.
plus
30%,
percent,
yeah.
right?
Right.
You know, and you mentioned the time rush. We're all healthcare providers, but we're all patients, and our families are patients.
Sure.
And I look, it's very real. You know, the perception that physicians are rushed is real.
Right.
They are. Many times, often through no fault of theirs, but
Correct.
that's real, right?
The idea of do more with less is in every industry, right? And patient care is no different, right? It just the stakes are much higher.
Right. If we could compare a physician assistant to a nurse practitioner, where is the overlap? Because you're right, you know, patients do interact with physician assistants, they do interact with nurse practitioners. But for the listeners, where is the overlap? How are they similar and how do they differ?
I think in the wards is the overlap. In the hospitals, the clinics, the offices, they're almost indistinguishable, right? You can work along someone in the ED and you don't know, aside from their tag, what their title is, the initials after their name. You're all diagnosing, treating, prescribing, patients, assessing, right? Those are all the same, particularly in inpatient environment. I think in the outpatient world, I think there's where you might see the differences between nurse practitioners and physician assistants. And that varies state to state, right, as you know, depending upon the ability for a nurse practitioner to open up a private practice independently is one thing that physician assistants don't do. So I think that's where you'll see more of the differences. But even if you were to say within that practice, the evaluating, diagnostic, prescribing for patients is the same. The care model is the same. So maybe more on the management business end, I think, would be some of the differences.
I see. And are you guys opposed to the opening of your own practices, or?
Yeah.
Guys, I know it's a little bit of.
It's a good hot topic, sure. And I think anyone would, have various opinions on that. So if you're asking me personally, would I want to open my own practice? I would personally not want to do that.
Interesting.
But I'm an inpatient person, so maybe that skews my mind, and Lara may
Emergency
have another
medicine.
idea. Yeah.
Don't want to open up my own emergency medicine
Right.
practice for
Yeah.
sure.
And Scott, you come from a surgical background.
Yeah, I worked in
Yeah.
surgical ICU.
So from a Northwell perspective, I think that's a great question. We are the top employer in New York State for PAs and NPs. As it relates to the country, we're top 4 employer in the country for PAs and top 10 for NPs. And when we talk about where does it merge and where does it not merge, I think from an education perspective, we both know it's a different educational path.
Sure.
Once they get in there, the difference is PAs are trained as generalists, and I never answered your physician's assistant, physician
That's
associate
okay, I didn't
question, but
forget.
that's where it comes from. PAs are trained as generalists, and Ps have the different certifications, right? So we are mindful at Northwell to understand which cert does that NP have, which training and education, so that we can place them where they're going to flourish, acute setting, ICU setting versus, the hospitalist, still in the inpatient, but a hospitalist service. But the beauty of it is what Scott's saying. We have many hybrid departments within our organization across the entire system where PAs and NPs are working side by side with their physician partners, and the PAs and NPs are indistinguishable one from the other.
So
Yeah.
you know what? Let's stick with training for a second. I can vouch firsthand to the training that you're giving your students, Scott, because I know you. I know most, if not all, of the faculty in the program. I know a lot of graduates from the program. You guys are doing first-rate training.
Thank you.
So dive into what that training consists of. How standardized is that? Like you mentioned, there's how many? 300 some odd
close,
training
over 300
programs.
now.
So obviously, there are going to be differences. So yeah, talk about that.
There is some slight differences for sure. Our accrediting body that certifies all PA programs in the States has very tight restrictions, analogous to maybe JCO in the hospital, right? And all of the things that you have to do, the metrics you have to meet, the self-assessments you have to do. And so that creates a lot of parity within programs, right? Every program, like I say, is going to give you the ologies, the cardiology, the pulmonology, right? And you're all going to do that. And you might do it in different ways, different lectures, different maybe use of technologies. PA program is essentially your first year is your didactic year, right? Your urologies, you're sitting and learning about anatomy, cardiology, pulmonology, pharmacology, learning how to examine a patient, laboratory values.
But
And
sorry
then-
to interrupt. Correct me if I'm wrong. I mean, you start clinical early too, don't you? Does
We
that
start
or let me
hospital
ask you this a
visits.
question. Does that start
Hospital.
in the first year as well?
Yeah, in the first month or so, we'll start doing hospital visits, right? So as you learn to interview a patient, that's probably the first thing you start to learn.
Right.
Then we send you to the hospital and say, go interview this patient. You'll do that intermittently the first year. Your second year is all of your clinicals. So you'll go through the accreditation, 7 tailored specific things that you'll do, right? Your pediatrics, your women's health, right? Your surgery, your emergency medicine, internal medicine, and so on. And then in our program, we give them 1 elective. Some programs will shorten the rotations, maybe give 2 electives, depending on how they function their clinical year. We give 1 elective that the students can take. So that's your second year. And then in our program, the students come back on campus for 1 final semester that we call the research semester. Sometimes I call it a transition to practice semester, where they do a research project, an original research project that they present on graduation day. But then we also do some technical skills, some OSCEs, right? Some kind of reinforcement and checking competencies before we send them out into the workforce. We have a built-in board review, so when they graduate, they're ready to take the boards the next day. We do things about, how to interview, how to build your resume, fundamentals of finance, because you're going to have a paycheck soon. What do you do with that? So those kind of transitions to practice we do in that final semester. They graduate, they take the boards, they get a job.
3 years or so, and that's
28 months.
Yeah, okay, and that's 28 months, and that's fairly standard. And end up with a master's level degree. I mean, they have the option, right? I think both of you have diplomat level degrees afterwards, or am I wrong? I mean, they have the option of getting
A doctoral
doctoral,
degree. That is an option.
Evolving
doctoral
thing,
degrees,
yeah.
right? But let's just go back to sort of, because we talked about the history a little bit of back in the 60s of how this all developed, and Dr. Stead drew on nursing medics and stuff, naval, military medics, and they had experience. Is that a strict requirement now? Do students come in now with that sort of experience, or what experience do they come in with?
Less so now. It used to be more. So every program has a requirement of healthcare experience and some shadowing type hours to come into it, because we want you to know what you're getting into, right? You have spent some time with a PA and talked to a PA, and they'll tell you about school and how their life in clinic and what they do, so you know what you're getting into. If you're going to go through the rigors and the expense of this program, we want to know that you know what you're getting into. So we want you to spend time and that you want to be in healthcare. The evolution of a lot of programs, ours included, is having younger and younger students come in. So part of our program, and a large part of our program now, 75% of the students come from the undergrad. So Hofstra has an undergraduate program. Right out of high school, you can roll into a PA track, and you'll do 3 years as an undergrad in a very stepwise biology, chemistry fashion, and then roll in your senior year of college. Is your first year in the PA program. You can't get lots and lots of hours as a freshman and sophomore in college. You just don't have the time compression. And so you're getting them less. One of the nice things is with Northwell as our partner, we've partnered with them to get them into the hospitals during those first 3 years to get them the shadow and to get the experience.
Right, which is tremendous, because clinical placement, I mean, we have this issue in nursing. I mean, it's a broader issue, is there's just not enough clinical sites, right? So to have that available is wonderful. How much of a difference do you think that prior training makes in the subsequent abilities of physician assistants? So if somebody comes in with, like the naval medics did, with tons of experience versus limited, how much does it all wash out in the end?
Yeah, so the data says, like board pants rates, graduation rates, the data says it's the same. Because I think the kids are better kids. They're better students now.
They're incredibly smart. I think it's so difficult to get in. How many apply?
1% acceptance rate to the program.
So,
over 2,000 to get it.
So they're really pushing hard in whatever the base of getting accepted is. These kids are pushing way above that. So if you're telling them you have to have X amount of healthcare experience, they're tripling that number because they want to be that 1%, because it's so difficult to get in now. The PA degree was a second career choice for me. So I went through the track of getting my bachelor's degree in political science. I thought I was going to end up maybe working at the UN. But I really loved...
There's still an opportunity. We need you. Bring your leadership skills there.
Maybe it's still there, right?
Yeah.
So I did a political science degree, but I loved science. So I did a pre-med kind of course load. And I ended up with a chemistry minor, but I took all of those prerequisites just in case, I guess, the political science didn't work. And then I landed in a healthcare job. So I worked in neonatal ICU for the Department of Health, kind of like checking off, making sure that the babies and the moms had gone through, the X amount of paperwork. Then landed another job in research for hematology oncology patients, actually still when Revlimid was a study drug. So I had all of this experience within healthcare. again, to the point of those medics, not the didactic, not the true understanding of the anatomy and physiology. And when I bumped into the HEMONC facility at this hospital, was all PA run with an attending. When I started bumping into these PAs and kind of getting a glimpse of the profession, I went back home and I was like, hey,
This is pretty cool, right?
I'm applying to PA school.
Plus,
Yeah.
you made the right choice because political science is a misnomer. That's not science.
True.
People are going to hate me for saying
Yeah.
that, but sorry. I mean, right?
It is not
I
a,
don't know
it's
how
not
you
a
came
true
up
science.
with that
It's
name.
like boxing; they call it a sweet science, right?
Yeah.
It's a science for everything. So
I know Ambassador West sounds nice though.
Yeah.
Right?
Yeah, no, we'll have to have you back for that. Yeah.
comparing NP training to the PA training that you guys just described, I mean, the first year kind of sounds very similar. We do pathophysiology, pharmacology, physical exam, and then the second year and the third year are kind of like clinical,
Right.
and they start to specialize in those years. The endpoint is a little bit different, right? So a nurse practitioner, they take their certification exam, and they only have to take that exam once.
Yeah.
Mm-hmm.
But you guys, you got to do it every 10
Every
years.
10 years now.
What is that like for you guys?
I actually
Yeah.
don't mind it because,
Really?
again, and I'm saying this now because I passed it last year, being able to crack that book open and study the stuff that I haven't been really thinking about. I'm a little biased, I guess, because I'm emergency medicine. And so we get to see a little bit of everything, right? Thyroid disease and TSH, T3, T4, and all, autoimmune. Those are not things that necessarily an ER PA is necessarily dealing with all the time, unless it's a thyroid storm, for example. Kind of getting into the details of that and looking at it and looking at the articles, I actually enjoy it. I say that now because, again, I passed my exam. 10 years from now, I might regret saying that.
We like honesty on this program. So that's,
Well, it's a take-home test now.
Is
Now,
it really?
You
Yeah.
can choose to have it
So
as
now
a
they're
take
flipping,
home.
yeah.
okay.
Yeah.
So I guess that's
Yeah.
not so bad. I mean, there's always continuing education. That's what we
Right.
do,
Yes.
So
We
That
have to
is-
do
yeah.
the continuing education
you have to do both.
plus the exam.
Yeah, plus, yeah. 50 credits.
Oh,
done,
man.
Yeah. That's at least oftentimes discipline specific, right? So I would go to the Society of Critical Care Medicine conference. You get there for 3 days. You get 30 credits, right? You're with your peers. That's not so bad. It entices you to do that.
so I just want to follow up. You mentioned discipline specific, and Lara, you sort of have a background in emergency medicine, and Scott, you have a background in surgery. So there's something we should mention for anybody considering a career as a physician assistant, physician associate. Is your profession is fairly unique, I think, in the fact that you could be doing dermatology 1 week and then decide that, whatever, it's not for you, and then you could sort of switch into orthopedics or something else. Am I wrong in saying that's
No,
fairly
yeah.
unique? And how did that come about?
That adaptability is quite unique and precious. One of the things that drew me to the field for sure. Yeah. And I would imagine they came out of that fundamental acute care kind of medical military core model where they kind of had to handle everything that was in front of them.
Yeah, jack
And it
of all
kind
trades.
Right.
Yeah.
And it grew from there.
And again, back to the physician's assistant, that's how it started, right? The name initially was physician apostrophe S assistant. That was the first nomenclature used for that, the first 4 class. And then as the programs evolved and other programs started evolving, they started having, okay, this group, we're not really training them as generalists. We're going to train them very specifically to the niche that we need. And then they started subclassing the PAs in the training. And then the generalist PAs became known as the physician associate.
Uh-huh.
So
I
that's the
didn't know
history
that.
of
Right.
the
Very interesting.
physician associate title. There was some pushback on that title. So the title went back to physician assistant. Not too long ago, the American Academy of PAs changed the title back over to physician associate, and is state by state dependent to pass and approve the change of the title.
Right, because when I go online and look, I mean, most often I see there's a slash mark. It says physician assistant slash physician associate.
Just call me a PA,
transition,
and I'm
yeah.
good.
And how did the sort of the more advanced training come about? I mean,
Yeah.
I think that's a trend for everybody. Physical therapists now, PTs are getting, diplomat level, doctorates and all this, and nursing, right? I mean, we have a DPN program and all. So how did that come about in PA world? I mean, was that just, hey, everybody else is doing it, we'll do it, or was there something else? Or
On the specific training?
for the more advanced degrees?
Like doctorate level degrees.
Yeah,
Yeah.
doctorate
Go for
level
it,
degrees.
Scott.
My opinion is yes, what you said, right? I think everyone's doing it, so we're going to kind of keep pace with what other people are doing. And so that's probably where it came from, right? PharmDs and everything else. Because it's not advanced clinical training, right?
That's more administrative
It's
research,
administration-
policy.
Yes,
right?
exactly. And I think So then maybe I'll talk myself a little bit, because one of the exciting things about PAs is their expansion to beyond the clinical world, right? Into academics, into research, into administration, industry, policy, politics, right? And so when you start to go into these other adjacent realms, then there are advanced skills that become useful, right? Skills in organizational management, skills in fiscal accounting and healthcare policy and delivery, some of these things that you could learn in an advanced degree, right? Because I could go and take a couple of classes, but if I'm going to go take a couple of classes, I might as well get a degree out of it and get an organized structure. So I think that's the organized direction of these diplomat programs now.
So I'm curious, I just want to sort of poke into one element of that in terms of, you'd mentioned research before, and again, how open is the broader healthcare world, so let's say JAMA or New England Journal of Medicine, to PA research? Is there a bias towards PAs publishing in, what would be considered MD-centric journals, or how does that work?
I have a publication, it's not in JAMA, but I have a publication. It was done with a physician, specifically looking at GYN population coming into the ER. I don't think that I've ever felt any resistance because I was a PA to have an article accepted. I also have a chapter in a book that was published. I really felt no resistance to it.
Which is great to hear, because listen, I mean, we in School of Nursing PA Studies and just broadly, and I know within Northwell, there's a big emphasis placed on collaboration, because that's just the way it should be. It works better for patients. So
that's how patients should be cared for.
It takes a village, it takes a team, and all this sort of stuff. So how about you?
I don't see any resistance, and I think maybe the evidence I see when I pick up my JAPAs, a Journal of the American Academy of PAs, I see used to be mostly PAs putting out the research, but now I see PharmDs writing articles in there and getting published, physicians in there getting published. So I think it's this collaboration of I'm doing some type of research and I want to get it published, and I'm looking at every avenue. So the fact that the JAPA journal is now recognized as well as JAMA
in the medical
and
community.
Like that. Yeah.
All right, that's good to hear.
So we spoke about doctorate degrees, right? But what about this new thing now with fellowships? Where does that come from? And this is a question from the students. I promised them that I would ask you guys. So where is the fellowship coming into play, and why is it necessary?
I love that question, and you should bring Andrew Rojan and Frank Rizzuto to the call.
To do that.
Oh yeah.
So you should bring them both
topic.
and have just a full-blown conversation about fellowship program. So I'll give you a little bit of my history and why I love the fellowship and I'm such an advocate for it. And we talked a little bit about the emergency medicine world that I lived through, right? My first job right out of PA school was a level 1 trauma center in New Jersey, very busy, active pediatrics and adults, with one attending overnight with one PI. And when I went into that interview, it was interesting. The physician said, we don't hire new grads, but I wanted to meet you. And I was just like, well, this is going to be the easiest interview I've ever had because I'm not getting the job. Long story short, I did get the job, but there was a caveat to it. It was for the first year, you're going to sit with the residents on Wednesday morning lectures. He gifted me Rosen's Emergency Medicine. I think it was like edition 7, both volumes of it. And he was like, no, I read it.
Read this over the weekend, right?
He's like, read this for the next year that you're with us.
Right.
And I have to say, my first 6 months, it was really hard. It really was. Here I am alongside critical care certified nurses, one attending, and then the rest of the attendings and PAs leaving the ED. We're running codes side by side with each other. The PA program really prepared me, but not to that level and not to that degree that I needed. And so really I started thinking about what is that transition to practice looks like for both PAs and NPs. When I moved to Northwell, I became the co-director of the EM fellowship program. Actually, with Dr. Eric Choi, we started our first recognized nationally, the first EM Global Health fellowship program, where we sent somebody to Africa for a couple of months and then have them come back over to us. Wow. And, I'm really a full supporter of that. I don't think that all employment tracks should lead through fellowship, but there's certain specific tracks that I think it's incredibly important and beneficial to both that new grad PA or new grad NP, regardless of whether they had nursing years of experience or not.
Yeah, I think it's interesting. It's sort of like you don't know what you don't know until you're in a situation
Correct.
like that, right? So it does boost them up. It bolsters them
The
up.
confidence level.
Yeah, absolutely.
Many of our graduate fellows are leaders within our organization, or publishing, or doing things outside of their clinical realm in quality or research. Kind of really bolsters not just the competency, but the confidence as well as a clinician.
Yeah.
So what's the breakdown gender-wise? I mean, there's certain professions, like I know veterinary medicine, it's like 3/4 women. Nobody's given me a logical explanation for why.
Is that real?
Yeah. 3/4 of veterinary medicine students are across the country are female.
It's overwhelmingly female.
So that's why
but
that's
it's,
why
I
they're
think, in
smarter,
the
right?
60s, yeah, exactly. Maybe in the mid-60s percentages of female to male.
So again, I never got a good explanation for veterinary medicine. Is there an explanation that makes sense for PA world?
I don't know. I don't have an answer like why. Yeah, that it is that way. I think they're smart enough to say, hey, this is a great pathway, right? Well, men are still staring at the crossroads trying to figure out what to do.
And I think we need to do, and we are, I know that from a PA profession perspective, we've been trying to do a much better job at ensuring that our population as PAs is representative of who our patients are. And that includes both males and females. And so they have been really looking at this. I will take a hunch at saying that when I decided to go back to PA school, again, it was a second career choice for me. I was married, I had one child in the way, and medical school really wasn't something that I was thinking about. But the fact that the PA degree was going to be 2 years was interesting to me, and where I could just say, okay, I could pause everything that I'm doing personally, kind of dedicate these 2 intense years into this,
Right.
and then revamp back.
So you can continue to live your life and still get the training and
Well,
start
you
another career.
you literally pause life for 2 years.
Yeah, but
and
I mean,
you go
2
to
years
school.
is 2 years.
2 years is not
versus
7.
a dozen or
Correct.
more. Hey, listen, I could
Correct.
just share my own personal experience. I think I've talked about it before. So I have 3 kids, and my dad was a doctor, and my wife, both her parents are MDs. So my oldest, my son, was interested in a career in healthcare. I said, hey, listen, I'm not going to tell you what to do, and I won't. But I pushed back fairly hard on a career in medicine, largely because of, the changes going forward. I mean, it's hard to predict what's going to happen, a year from now, let alone 12 years from now. Training is long, and I've made the recommendation for considering a career in nursing or PA. Yeah, for a lot of the same reasons. I mean, look, that's a reality. To train to be a medical doctor, there's some tendency to want to make it even longer, which is add a research year, and
Right.
it's like, my God, 4 years of medical school and 5 years of residency and a couple of years of fellowship, and throw in another research year. It's like, holy smokes, right?
Yeah.
What's the biggest challenges for an average graduate coming out? And you mentioned talking to them about practical issues in terms of billing and, starting a practice and all sorts of stuff. What are the bigger issues that are faced? Everybody gets a job, right? I mean, that's
100% job rate. As you mentioned, the Bureau of Statistics, 30% growth, right? So you'll get a job. So a lot of times they go out there and they want to do very niche things. So that might be a little bit more difficult to find that pediatric hematology job versus a job, in pediatrics in general.
If
right?
anybody's out there looking for a pediatric hematology job, we
You
have
got
one.
it. Yeah.
Right.
Yeah. I'll take my money at the end for that promo.
Right, and again, Northwell, we could toot our own horns. We're leaders in the
Right.
field. We're doing it as well, if not better than anybody else. Sorry to interrupt
so
you.
I think it's just deciding on where they want to go, what field they want to work in. We were with the seniors today, and a lot of them are like, oh, maybe I want to do emergency medicine. They're like, no, maybe I want to go do this fellowship in pediatrics. It's very disparate things. So they're overwhelmed with the options. So it's a blessing, but they're just trying to sort through it. I think that's the thing I see the most of. And then we remind them, go do emergency medicine, and then 2 years later, go shift and do something else.
Right,
Or do
which is
something else
really
on Thursday.
fantastic. It really is. You can't talk that up enough.
So, one more question for you.
Yeah.
Advanced clinical provider, right? We spoke about the similarities of an NP and a PA. But where does that term come from? Is it like a Northwell specific term?
It is.
The ACP term is Northwell. People use APPs.
Correct.
I see.
Or mid-level providers. in
We
other words.
don't use mid-level providers.
Why? Does that have a bad
It's
connotation?
a bad connotation.
There is a bad connotation that they're providing mid-level care.
Oh, that it's not as high a quality or whatever.
Correct.
Yeah,
And so we no longer use that term.
I get that.
The ACP acronym is a Northwellian term for sure. APP is much more widely recognized across the nation. Obviously, everyone knows we integrated with Nuvance now, and they use the APP term. We use ACP. So that acronym is now in the table for discussion. Talk to me maybe in a year from now. We'll see where we landed.
Hudson Valley
So
term.
for those of out there who don't know about this, I mean, just explain the acquisition or merger or whatever with Nuvance, which is basically an expansion of the system. Just if you could, just for a minute or two, tell people what that's all about. I mean, we already have a huge system in Northwell, and now we just...
And now we're growing, correct. There is a new acquisition with our partners at Nuvance, which is adding 7 new hospitals and multiple other ambulatory practices. From a ACP or APP perspective, that's another 400 plus APPs. Just some more work for my team and but it's work that we love to do. When you love what you're doing, you never work a day of your life, right?
Yeah, that's absolutely true. Correct me if I'm wrong, it's mostly expanding into Connecticut, or is that?
Yeah, upstate New York and Connecticut region.
Right, which is fantastic.
Yes.
And, I'm sure there's more to come. So I want to thank you both, Lara West and Scott Gould, for...
Thanks for having us. This is a lot of
fun. I promised you'd be fun, right? We kept it real, so that's great.
I loved it. Thank you so much. I
So
appreciate being here.
that's fantastic. Thank you out there for joining in on another hopefully informative episode of Nurse to Health. So on behalf of myself, Dr. Robert Gluck, and my wonderful co-host, Kareem Nagdala, and always, with the wonderful support of John Mullen, our engineer, this is another episode of Nurse to Health brought to you in collaboration with the School of Hofstra Northwell School of Nursing and Physician Assistant Studies. Until next time, stay well.